Yeah. So what we're seeing in a lot of departments is a few different operational flows that do help that, right? And high level use of technology if they don't need to come to the ER in the first place. If they show up in the ER, obviously we're going to take care of them, right? That's the way the emergency department works. If you show up in our emergency department, we know that you feel you have a life-threatening emergency. When there are things what we would call those ESI level fours and fives, and sometimes that can be actually something, major. It can even be a pretty sprained wrist or even like a broken finger, that still can constitute as what we call low acuity because it's not a threat to life or limb. And that can be a quick workup. So the great thing about, the use of technology is if we can get that patient, although they might be kind of stuck in the waiting room for 3 hours because there's no room available, putting technology in front of the patient, having a provider be able to engage with that patient and order the x-ray, order the interventions that are needed almost immediately, rather than having to wait the whole traditional process of getting to the back of the emergency department in front of a in-person provider. If we can get some of those orders started earlier, we can increase that throughput for even those low level cares, for low level acuity needs for care. And then I'll get into, I guess, everything that's in between too that takes a long time. So belly pain workups, all of your what we would generally lump into ESI threes, headaches, things that take a lot more investigation. Again, we're going to use technology to ensure that patients can get to that care faster. As far as what we're seeing across the country, it's actually probably international, but I won't speak too much because that's not my area of expertise. Uh, we're seeing care models with different flows. So you'll have a fast track for your really low level acuities. You'll have sort of the regular track, which involves typically hours and hours and hours of waiting in the waiting room before you get a bed. And then naturally anything that's incredibly high acuity, your strokes, your traumas, gunshot wounds, heart attacks or STEMIs, things of that nature are going to go straight back to the room where there's a full nursing staff and an in-person provider. It's that in between that tends to get bogged down. And these patients need seen, like I said, these belly pains. It could be food poisoning. It could be something that's going to pass on its own and nothing that you can do a whole lot for. Or it could be appendicitis, right? It could be something that needs to be diagnosed and figured out so that surgery can get scheduled. And I think that's where it gets scary for us healthcare providers is we want that data. We want to know what's going on with the patient as soon as possible. We certainly cannot afford to wait, the waiting room standard 4 hours before we start what we call working up and testing that patient to find out and dig into what's going on. And that's where I'm seeing the biggest changes, and honored to get to work with eVisit. That's where our technology excels, and we've got models that indicate that, and we've seen some really great outcomes at the emergency departments that we work with.